Friends, we just discussed classical ascites, which is secondary to liver pathology, that is cirrhosis of liver. And you would recall that when we were discussing ascites, we also discussed something called Chylous ascites and pancreatic ascites. Both these are rare. Chylous ascites most often is secondary to surgeons' adventure come misadventure. You may not see Chylous ascites. I think I've seen Chylous ascites maybe once in my whole life. But it's nice to know what is a Chylous ascites. You will never get a case of Chylous ascites in an examination. You might get in your theory paper a brief discussion or a short note on Chylous ascites. I don't know, how often have you seen ascitic fluid which looks like a milk? What is also called as muddy ascites, a milky ascites, which looks like as if this glass is full of milk. It's not a classical translucent ascites that you see. And this can be because of high proteins or due to presence of large volume of fat in the solution. This may be chylous or pseudochylous. Sometimes an infectious ascites may look like this, especially if it is spontaneous bacterial as peritonitis or SBP. The fluid may look something like this. So it's important to know, are you dealing with a Chylous ascites or you are dealing with non-Chylous ascites. In good old days, the simplest bedside test to differentiate this kind of fluid, whether aspirated from the thorax or aspirated from the peritoneal cavity, was or to put few cc's of acetone into the fluid. Since acetone can dissolve the fat, if it becomes clear, you are dealing with a Chylous ascites. If it remains the same color, is called pseudochylous ascites, which can be because of any number of causes. The other classical feature of Chylous ascites is alkaline. Its specific gravity is more than 1020 or more than 1019. With a classical ascites fluid, the specific gravity is never that high. How do you differentiate? As we said, the scientific method is you measure the triglyceride levels in the fluid. If it is more than 200 milligram, it is Chylous ascites. If it is less than 200 milligram%, it could be anything. In addition to triglycerides, the protein content is also higher. That's how you label that are you dealing with a Chylous or a non-Chylous ascites. A word about how is lymph produced. Lymph is produced by the intestine and by the liver. 90% of it comes from intestine after the absorption of triglycerides broken down into fatty acids and absorbed with the chylomicrons absorbed into the lymphatics of the intestine, gets into the retroperitoneal lymphatics, gets into cisterna chyli, which is situated at the level of L1, ascends up as a thoracic duct at the level of T5, crosses from right to the left side, ascends up into the neck and opens at the junction of jugular vein with the left subclavian vein. The funny part is it begins at the level of L1, enters thoracic cavity through aortic hiatus and crosses from right to left side at the level of T4, ascends up and opens into the junction of internal jugular vein with the subclavian vein. There is a counter lymphatic duct was called as right lymphatic duct, which starts in the neck and comes down. Do they join together? A big debate. Now, if there is a breach in the lymphatic system anywhere, it can lead to a leakage of this fluid and lead to, if it is the neck, we call it as thoracic duct fistula, which is not uncommon but not common either. I would say it's not rare and manifests in the form of thoracic duct fistula following radical neck dissection or sometimes after surgery on the thymus, thoracic gland. If the same thing happens in the abdomen, it leads to leakage of fluid into the peritoneal cavity and leads to the formation of what is called Chylous Ascites. If that fluid accumulates into the thoracic cavity, it forms chylothorax. And after esophagectomy, though thoracic duct is deep to prevertebral fascia, it can get damaged during esophagectomy and can lead to leakage of lymph and produce chylothorax or chylous abdomen or Chylous Ascites. Most of the cases, over 90% of the cases, Chylous Ascites is secondary to trauma. Majority of the times, I would say over 90% of the times, the trauma is in the form of surgery. The surgery, which involves retroperitoneal lymph node dissection, like you do it for testicular tumors, radical renal surgery, surgery on the aorta. You may damage this retroperitoneal lymphatics and lead to leakage of chylous fluid into the peritoneal cavity.